Okay, we'll go ahead and begin. Good evening. My name is Doug Hanto, and I'm the co-chair of the Surgical Ethics Working Group in the Center for Bioethics at Harvard Medical School in Boston, along with my co-chair, Dr. Theresa Williamson, a neurosurgeon at Massachusetts General Hospital. On behalf of the Surgical Ethics Working Group, I would like to welcome everyone to our final session of the 2025 Harvard Surgical Ethics Conference. Our final session this evening is Implementation of AI in Surgery, Ethical Considerations. We have individuals registered from the conference from around the world, and we would like to thank you for getting up early, staying up late, and taking time off from work or leisure to join us this evening. I believe we have an exciting 2 hours ahead of us. I would like to review a few housekeeping items before I introduce our topic for this evening and our moderator. We would ask that you submit questions at any time using the Q&A feature found in the Zoom meeting controls at the bottom of your screen. Selected questions will be discussed after the presentations. If you have any technical issues, please use the chat feature to send a message to all panelists, and a staff member will help. We'd ask that you continue the conversation online with hashtag HMSBioethics in your social media post. If you're interested in other webinars, bioethics news, or HMS educational programs, please subscribe to the center's biweekly newsletter, bioethics.hms.harvard.edu/subscribe. It is my pleasure to introduce this evening's moderator, Dr. Jonathan Marron. Dr. Marron is a pediatric oncologist, health services researcher, bioethicist, and educator at Boston Children's Hospital and the Dana-Farber Cancer Institute. In addition to his clinical role in pediatric hematology and oncology, he also serves as a clinical ethicist at Boston Children's Hospital and an assistant professor of pediatrics at Harvard Medical School. John is also the director of clinical ethics in the Center for Bioethics at Harvard Medical School. Dr. Marron's research focuses on the intersection of ethics and decision-making, with a particular interest in novel and emerging technologies, including those with uncertain risks and benefits. His bioethical areas of interest include pediatric ethics, ethical issues in genomics, informed consent, healthcare disparities, and research ethics. He will be introducing this evening's speakers and moderating our panel discussion. Dr. Marron?
Thank you so much, Doug, for that gracious introduction and for the opportunity to moderate today's session. And thanks so much to all of you for joining us for our fourth and final session of the 2025 Harvard Surgical Ethics Conference. As Doug mentioned, I'm John Marron. I'm actually not a surgeon, but despite that shortcoming, I'm incredibly excited for today's session. It's been an absolutely gorgeous day today in Boston. So whether you're local in New England or anywhere else in the world, we really appreciate you taking the next 2 hours out of your day to join us to explore this fascinating and really important topic. Today's session will examine the ethical considerations regarding implementation of AI in surgery. For those who joined us for the first session of this year's course, we learned a little bit about the role of AI in education, and particularly in ethics education. And it was clear during the Q&A session that people were incredibly excited to learn more about AI. So today's your chance. We're joined today by three really spectacular speakers. I'll give a little bit more of a complete introduction to each just prior to their talk. But first, Dr. Francis Shen will speak to us about AI and patient privacy, data security, and ownership. Then Dr. Theresa Williamson will examine the over-reliance on AI and the loss of the art of medicine. And finally, Dr. Rohaid Ali will speak about reclaiming voice with AI and other applications. As with prior sessions of the conference, each of our three speakers will give their presentations, and then we'll have a combined Q&A session with the remainder of our time after the three talks. You're welcome to enter questions for any of the speakers at any time using the Q&A function, not the chat function, please. And we'll get to many of these as we can, as Doug was mentioning. If you have technical questions, please send a chat message to the panelists, and somebody will respond to help you. All right, that's more than enough for me. So without further ado, I'm thrilled to introduce our first speaker. Dr. Francis Shen is a professor of law and faculty member of the graduate program in neuroscience at the University of Minnesota, where he directs the Shen Neuro Lab, the Shen Neuro Law Lab. An expert at the intersection of neuroscience, AI, law, and ethics, Dr. Shen is also a member of the HMS Center for Bioethics, where he taught the center's first bioethics and AI course. Dr. Shen also is co-director of the Neurotech Justice Accelerator at Mass General Brigham, which is a Dana Center initiative. He co-leads the NIH Brain Initiative grants and consults on the NIH Brain Bridge to AI project. Dr. Shen received his BA from the University of Chicago, his JD from Harvard Law School, and his PhD from Harvard University. Today, Dr. Shen will be giving a thought-provoking talk entitled AI in the OR, 5-Step Strategy to Address Ethical and Legal Issues Emerging from the Deployment of Artificial Intelligence in Surgery. Dr. Shen.
Thank you, Dr. Marron. Thanks to Dr. Hanto and Dr. Williamson for making this possible. And as was said at the outset, thanks to all of you for spending some time with us tonight. I've got about 25 minutes to give you an overview of ethical and legal issues in AI. Normally we have a full semester to go through some of these issues, and rather than try and cram everything in, what I've done is cherry-picked a few issues that I think are especially salient for ethics of AI in surgery, and a few provocative questions and recommendations that I think might spur some discussion and reflection. No disclosures to make, but want to acknowledge many funders, including, as was mentioned, an NIH Bridge to AI project. Thanks to all those for making this work possible. So I'm going to talk about how AI is being deployed in surgery, but primarily with the goal of thinking about who gets to decide how it will be decided. That's the punchline. So just brief introduction to my work. I'm going to give you the top 10, a little top 10 list of the top 10, in my mind, ethical and legal issues with AI in surgery that should be on your radar screen. And then I'm just going to pick one complicating factor, which is, oh, hey, wait a second. What exactly is artificial intelligence? We'll suggest to you that the definitional question is really challenging. And then I'll just lay out, at least in my mind, a basic approach for whether you're leading a department or an individual in a unit. You could think about a strategy for addressing these issues. And we'll end, because I'm a lawyer, with a little bit on legal liability. What happens if you don't have a strategy, whether it's mine or another one? Okay, what's the punchline? Well, the punchline is, as seen in many headlines and recent articles, the future has arrived. The future is now. Artificial intelligence is already being deployed across the surgical landscape, and it will be further deployed in deeper and more broader ways in the years to come. So how is it being deployed? We don't have enough time to talk about the many different ways. I will simply, and it's a wonderful chart from Juni et al. 2024, and you can check out the references for the more details. I like this chart because it's preoperative, it's intraoperative, it's postoperative, it's developing strategies, it's early diagnosis, it's actually using the surgical robotics, it's afterwards about discharge planning, it's everywhere. So the question is not, should AI be used in surgery? Because the answer is it will be, and it is being used. The question is how and who gets to decide. And I want to throw one other question out at the very beginning. It's going to be on the next slide, but I want to set it up because most ethics of AI talk kind of have this rhythm. They talk a little bit about how the AI might be used, and then they give you a laundry list of all the concerns about why you shouldn't or why you should be hesitant about using AI. And those are important things to do. I've done some of that. I'll do a little bit of it tonight. But I also want us to think about this question. What are the ethical costs of moving too slowly to deploy AI in medicine? What are the ethical costs and potentially the legal liability? And I'll just give you this nugget. Imagine you had a colleague who came to you and said, oh, what surgical tools do you asked them, what surgical tools do you use? And they said, I use the same surgical tools I've used since 1982, and I've never changed. You would say, wait, that can't be right. You've got to move. It's 30 years later. The thing with AI is that 30 years may happen in 30 days or in 1 year, and something may suddenly be outdated. And so what are the ethical costs of moving too slowly and too quickly with AI? All right, so that's an overview, a quick introduction to what I do in the work. Our lab, the motto is every story is a brain story. And we look at two big questions. One, we say, all right, how can neuroscience and AI change the law? A lot of ethical issues involved. It's really the second one here that we're focusing on. How can legal and ethical governance of neurotechnology and AI improve outcomes? And that's really the question tonight. You want to improve surgical outcomes? It's going to be legal constraints and ethical constraints. How do we do that? And I use those terms very broadly to think about issues around justice and diversity, as well as ethical, legal, and social implications. I've been doing this work for about 15 years. We started our AI in the Law chapter back in 2010 when AI looked very different. And it's only been recently that sort of the AI ethics has caught up. As of 2020, just 5 years ago, for instance, in law schools, the same is true in bioethics program, only about a quarter of programs were teaching in law and AI or ethics in AI. Today, of course, there's been a sea change. I won't talk much today about ethics in surgical research, but commend you and included in the slides and the references. We just hosted a big conference with many Harvard colleagues as well around ethical use of AI in research. I'll focus on clinical work tonight. All right, so let's get right to it. What are, drum roll please, the top 10 issues? Well, I think these categories, which I want to say at the outset are broad categories, they're also not mutually exclusive, but I think almost all of the ethical concerns you'll hear about AI in surgery, and probably AI in clinical medicine more broadly, can fall into these 10 buckets. First of all, and it sounds like we're going to hear a little about this in the next presentations, when, if at all, do we need to keep humans in the loop? What is different if it's a robot instead of a human? For which task will humans become obsolete? And is that a problem? So what role for humans? Big question. You'll hear more about that in the later presentations. Second, foundational safety. Under what conditions is the AI safe to use? Are the protocols in place? What about quality control and quality improvement? Maybe the robot surgical tool was okay in January, but 6 months later, is it still functioning appropriately? So some basic questions around safety. These are new tools, and that means people have to be trained on these new tools, whether it's a large language model or a surgical robot. Our courses, and I'm glad that this course is including AI, CMEs and medical school courses and additional trainings accounting for that. Is there a manual? Has everyone read the manual? Again, some basics around education and training. Fourth, privacy and security. This is a major, major issue. When the AI is, and I'll talk a little about this in a few moments, gathering a bunch of training data, where is that data coming from? Where is it going? Who owns the data and who controls it? Again, we could spend multiple hours just on this single question. It definitely deserves a place in the top 10. So does this next issue, which you've probably heard about, which is bias. I do put it in quotes because defining bias is also very difficult, and inaccuracy in systems and tools. Are the training data sets for which an AI was trained sufficiently representative to give you confidence that it was trained on group A, but you want to use it on group B? It was trained on adults. Can you use it on children? It was trained on children in country A. Can you use it on children in country B? These sorts of questions emerge. They're not unique to AI, but they're pervasive and important. A sixth issue is around transparency and explainability. And this has heightened importance when there is machine learning, when the system becomes self-reinforcing, and where at some point it may not be possible for the human to know exactly how the AI system came to the conclusion it did. What do you do when you're explaining that to a patient or to your colleagues? Do we need to demand a certain level of transparency and explainability? Moreover, to what extent do you need to alert patients, either at a system level or at an individual clinical level, that you've utilized AI, that you are utilizing AI? And what does that conversation look like? Another big issue, and maybe you'll hear a little bit more about this tonight as well, are the patient impact, both, of course, basic question, is it going to improve surgical outcomes, but also how will it affect access to surgery and the distribution of surgical resources? Will it exacerbate inequities, or could it potentially address them? Boy, I've had to wait 3 weeks, 3 months, 3 years, perhaps, to get access to some human surgeon, but maybe some of these new tools would allow access much quicker. Labor market impact is a major issue that I won't have time to talk about tonight, but it's affecting all sectors in which AI shows up. By what principles will labor market decisions be made, and what protection should be in place for humans? Environmental impact, another major issue that I won't talk about tonight, but I just want to flag for you that these AI systems use a lot of energy, and that energy has an environmental impact. It's often hidden, it's often far from the site of the use of the AI, so we don't see it, but this is a major issue. It'll become a major issue in the headlines, I guarantee, in the next few years. Finally, another issue that I will not have time to talk about, but I had to put in the top 10 list, which is there a point at which a system becomes so advanced, an artificial intelligence system, that it demands some of the same protections and rights and moral status as biological intelligence systems, namely humans and other types of non-human animals who we afford some moral status to? A great question, one that we spend an entire 2-hour class on in my seminar, and one that I won't be able to talk about again tonight. So these top 10 issues, and they're high-level categories, there are many sub-issues, I think cover the landscape of AI ethics issues, and certainly they're going to be confronted heavily, many of them, especially some of these first 6 or 7 in AI and surgery. And across all of these, we have a problem, which is, what is artificial intelligence? It doesn't make a lot of sense to me to talk about the ethical and legal issues of AI until we know what AI is. And I ask you this question. I'm going to give you a headline from 1970, not 2025, from 1970. Eye surgery history made at Ann Arbor. Operation done via microscope. And this is sort of, it's kind of, you're seeing there, this is the type of eye surgery that is now possible with the microscope. And they go on in this newspaper article to say, wow, this amazing new technology. We could never do it before. Our human eyes wouldn't allow us, but this new technology did. Is the use of cameras and microscopes in surgery the use of artificial intelligence in surgery? Why or why not? And I could give you a whole bunch of other examples, right? Is the use of Google, is the use of Microsoft Word with spell check and grammar check when you write up your notes, the use of artificial intelligence? Why or why not? And the reason that this isn't just an academic exercise is that when you establish your policies, or when you set some ethical guidelines and you make reference to the use of artificial intelligence, you better be darn sure that you're as narrow or as broad as you want to be for that definition. It has real implications. So how has the field defined artificial intelligence? Well, here's the challenge. We have to have some definition of the term, but no one agrees on how it should be defined. In fact, there's an entire, and I put this link in the references, you can check it, there's entire literature on telling us that we can't define it. Here's a quote from one of the leading articles. It is well known that there is no widely accepted definition of AI. So we all agree that we can't agree on a definition. So what do? Well, rather than define artificial intelligence in a way that it would maybe satisfy, if you're a philosopher, a lawyer, like from first principles, we kind of cheat, because instead of defining it, we describe and categorize AI into different types. And I'll give you just a couple of examples of how this is done. One way to do it is to describe AI by how powerful it is or how powerful it can become. These are what are sometimes called AI's capabilities. What is an AI system capable of? And broadly, we could think of narrow AI, so it's only capable of like certain programmed tasks. We could think of more general AI. This gets like human level intelligence, the things that sort of you might do as a surgeon when you're confronted with an issue. You use all that information that's, you've gotten over the years, you're confronted with a new case, and you put it all together, right? You do the human thing, you put it together, use some generalized intelligence. That's general AI. And then there's the possibility of, hey, humans can do pretty well, but maybe we could be superhuman, super AI, right? So that's artificial intelligence based on capabilities. There's another way to think about it. They're not mutually exclusive, and that is to think about, well, what does it do? These are its kind of functionalities, what it does. And again, oversimplified, but broadly, to some extent, is the system self-aware? It's kind of aware of what it's doing. There are some machines that sort of are able to engage other humans, like a theory of mind. Some may have limited memories, and some may just be sort of reactive machines. They can just react. Still, another way to think about AI is to consider how they're sort of related to each other, like those, Russian dolls. And this is often done when we talk about generative AI, such as ChatGPT. And here's an example. So broadly, artificial intelligence in this view is, computation to do tasks that we typically expect humans would need to complete. Machine learning is a version where this system is taking in data and learning to improve its predictions over time. It's got some ground truth. It compares its predictions to ground truth, and it gets closer and closer by refining its model. Deep learning, sort of a similar idea, but it's able to sort of make more informed and more intelligent decisions by learning from its data. And then generative AI, the idea to create brand new content in the form of text, images, etc. All right, so we could go on, and indeed many people have, not just for hundreds, but for thousands of pages about what AI is. I can't tell you what AI is. What I can say is that if you're going to have a conversation in your department, in your unit, in your hospital about your policies on AI, I hope on day one you have some agreement on what you're talking about. And I go back and ask you again, is the use of microscopes and of other technologies you're already using AI? Just one more thing, because I think it's fun. Let's give you something that you can go home and impress everybody at the dinner party with. You've heard of ChatGPT, but do you know what the G and the P and the T stand for? Well, you do now. So the G is generative, meaning it's able to generate. It's just basically fill in the blanks. What comes next? What word comes next? It's pre-trained because there's a whole bunch of stuff that it's trained itself on already, namely all the stuff it could find on the internet. And then the transformers, the hard part, we won't get into any of it, but it's a particular type of deep learning that make it good at language modeling. I'm not going to go through, in the interest of time, these details. They're in the slides, but I do want to say that ChatGPT does, I agree with my colleague here, who says they do exactly one thing. They take in a bunch of words and try to guess what word should come next. It is a pretty secret sauce, but I'd agree that our first instinct when interacting with a large language model should not be, wow, these things must be really smart or really creative or really understanding. Our first instinct should be, I've probably asked it to do something that it's seen bits and pieces of many times before. All right, I wish I had time to talk about all of that, and we could perhaps in the Q&A, but to stay on time, I want to move into some practical recommendations. How to succeed in a period of rapid technological change. So these are high-level steps, but I think they're important because they start out and they start the conversation. So one is, I think every unit, whether it's a unit on teaching, how are we going to teach with respect to AI, with respect to surgery, how are we going to train, what's our policy with training our new residents or our medical students in surgery, what's our policy for using LLMs in the OR, there needs to be at least some interim policy, or at least an email, initial guidelines. And I hope at this point, by sort of April 2025, that you already have this, or at least the groundwork of that. If not, like, stop now and go set up some interim policy, as well as, well, I'll get to this in a second, sort of a policy for yourself. All right. There's no one best way to go at those top 10 issues. You're going to have, just as there isn't a single best way to sort of decide, what patient population are we going to go at? What's going to be our specialty? But I think this is maybe the most important step, which is, all right, how are we going to approach AI given our units, our hospitals, my own values, and apply those to those top 10 issues. Equally important is that it shouldn't just be, your own group sitting around coming up with this, in my view. There's a lot of great work being done, and I'd encourage you to look at it, about inviting then members of the community, including patients, providers, support staff, the general public who live around the hospital, to join that conversation, right? So you've got some initial set of how we're going to implement this. You've got engagement with the community to navigate it. And then you've got to write that policy, revise it, publicize it widely. I think that I haven't seen as many units get to 4. Within hospitals, there are policies that have been drafted. I don't know that they've engaged the community much in drafting those policies, but hopefully you can get there soon. And once you do, you need to establish an annual review process, because what may be a great policy in 2025 is no longer a great policy in 2026. Now, as you develop these policies, and I'm going to go back to number 2, and I'm going to go back to that key question I asked at the beginning, what are the ethical costs of moving too slowly? In 2025, at this moment, I think eventually this stuff's going to, of course, you're going to have a policy, right? And of course, you're going to have all this, but we're in this moment of really fast-moving change. And I think for surgeons, there are 2 poles, 2 extremes, and then somewhere in the middle as to where you want to be with respect to this fast-moving change. And I'm going to capture them both in the next slide with 2 different quotes, very different approaches. So one, Jim McCartney argues, actually Dr. Eckhoff in this article by McCartney says, I'm concerned about the rapid adaptation of AI in our daily lives, but with respect to application of AI to medicine and surgery, we're not moving fast enough. Others strongly disagree. So this was just from last year, from scalpels to algorithms, the risk of dependence on AI in surgery. And I think we're going to hear more from Dr. Williamson on that. If you look historically, and historians of medicine have, this is a great piece, Innovation in Surgery, Historical Perspective, what you find is that there are ebbs and slows. Ultimately, there's a rapid expansion of medical capabilities and procedures. And this expansion leads to a slower period of technological refinement and consolidation of approach. This is where we're headed, folks. So my talk will be completely obsolete in perhaps even a few years, where everyone's sort of figured out where they're going to fit into this AI landscape. However, this is where we are right now, where initially physicians may try different techniques building upon a given enabling technology. We're not to the place where one will be widely adopted and others discarded. Where we're at is in this period of experimentation, and you and your departments and units and hospitals get to decide, how do you want to handle this? Some will be early adopters. And since some surgeons are technologically savvy and relish new technology, they found they would be early adopters. Others, since many surgeons tend to be risk averse, long periods of avoidance of change may be seen. And I think both of these are ethically justifiable. On one hand, you might say, we think it's difficult to move too slowly. It's ethically problematic to move too slowly. We need to adopt quickly and rapidly. On the other hand, you might say, we should not be the first adopters. We should let our colleagues or other units or other hospitals figure it out, and then we should adapt once it's been worked out. So consider all those concerns, the top 10 concerns. Consider also the ethical costs of moving too slowly. Figure out where you want to be on that landscape. Early adopter or wait and see. I don't think there's an ethical distinction in terms of one being better than the other, but I do think it's problematic if you don't know why it is you're doing. You haven't articulated that, especially as a unit. All right, so one fun last slide, just because. What could happen if you don't follow my strategy or something like it? That is, you don't establish a policy. So here are just three of the many avenues to legal liability related to AI and medical practice. 1, malpractice. The word you don't want to hear, the reason that lawyers and doctors fight too much. The evolving standard of care is moving rapidly here. And I could see lawsuits, though I've had my students be looking for them. They're just starting to emerge. We don't have a big body of case law yet, but you can see where they're going. The sense is that either because you adopted too soon, that's kind of where they are right now. I think we'll see soon a little wave of you didn't adopt of too late. Those standards of care are rapidly evolving. Understanding where they are and where you fit is important. Second, this is a big one in a period of rapid experimentation. Negligent oversight of individuals in your system or your colleagues. That is, you should have been aware that your colleague's surgeon, when preparing for the surgery, was using an LLM to figure out the best strategy for this surgery. And perhaps that was problematic. And even if it wasn't the hospital policy to do so, or even if the policy was explicitly not to do so, unless there's oversight and accountability and measures for implementing the policy, one might be liable. The other way that one might be, another way is also, as I related, as mentioned, around data privacy and data control. Is the system, especially say a system that's relying, say, heavily on the electronic health record data, is that data being properly monitored? Now, at the hospital level, I think there's a lot of attention to this issue, but it's a major issue. All right, third one. Use of AI to improve evidence in medical malpractice lawsuits. This is, again, kind of just for fun, but doctors aren't the only folks figuring out how to use AI. Lawyers are using it also. And I'll give you just one example. Typically, these lawsuits work like this, where, as you know, the concern is the lawsuit says you did X and you should have done Y, or you didn't do Y, right? You didn't do this thing. And it usually further and goes and says, we've got a bunch of other cases where we show that, this should have been done. And then usually the defense is something along the lines of, yes, but given these particular issues that the patient faced, this was the appropriate course of action. What if you had a legal research assistant who could not just look at your case and a few other cases, but could look at millions of other surgical cases and could place your case as a pure outlier, right? These are the sorts of things that lawyers think about when they're using this technology. So you're going to have a battle of AI as well. And of course, you can also use it in legal defense. All right, I'm at time. Here's my contact information. I'll put it in the chat as well. It's in the slides. You're welcome to contact me with more. We'll talk more in discussion. Big picture takeaways. AI is already in surgery. And the question is, who is going to decide how the policies are made with respect to further using it and disseminating it? Are you going to be an early adopter? Are you going to wait and see? Figure that out. Write the policy, communicate and enforce the policy, and you ward off a lot of these ethical and legal issues. If you don't do that, if you just say, oh, it's the Wild West and they're doing that and she's doing that and I don't know what's going on, expect not just lawsuits, but ethical concerns and ultimately probably lack of trust from your patients. All right, I'll end there and thanks.
Thank you so much, Francis. Already so much to think about. As a reminder, we'll save all of our questions and discussion until after the three of our speakers are done. But please feel free to start entering questions into the Q&A box, and we'll get to as many of those as we can. Our second speaker today is Dr. Theresa Williamson. Dr. Williamson is a neurosurgeon and surgical ethics researcher at Massachusetts General Hospital and member of the HMS Center for Bioethics. She cares for people with all types of spine disorders, as well as brain and spinal trauma. Her research focus is neurosurgical decision-making and patient-doctor communication, as well as healthcare disparities. She combines bioethics theory with empirical data science to tackle complex decision-making problems in neurosurgery. Dr. Williamson is a graduate of the Yale School of Medicine, as well as Yale College, where she was a varsity soccer player. After medical school, Dr. Williamson completed a neurosurgery residency at Duke. She then completed an intramural fellowship at Duke as part of the Combined Neurosurgery and Orthopedic Surgery Complex Spine Fellowship. She also completed the University of Chicago McLean and American College of Surgeons Surgical Ethics Fellowship. Dr. Williamson now is Assistant Professor of Neurosurgery at Harvard Medical School and co-chairs the Center for Bioethics Surgical Ethics Working Group. Today, Dr. Williamson will speak to us on the topic of over-reliance on AI and the loss of the art of medicine, perspectives of a neurosurgeon. Dr. Williamson, the Zoom floor is yours.
Okay, fantastic. Thanks. Sorry about that. Thank you so much for the introduction. I'm worried that many of us are running away now to create an interim policy in AI and surgery, because I think, unfortunately, several of us work in institutions that are still catching up to this technology. And so great food for thought from Professor Shen. It's been really fun to work together at the NJAM Neurotech Justice Accelerator here at MGB that we co-direct. And so I'm going to talk today, as Dr. Marron mentioned, on over-reliance on AI and the loss of the art of medicine. So these are my disclosures, nothing relevant to the talk, except for also gratitude for the funding that helps to support this work. Okay, so I'm going to start out with a case, and I think the stage is kind of set for what we know and what kind of data points we have from AI in surgery. And so this is a patient that came to me because they had many prior opinions, had a very complex medical and psychosocial situation, and had this deformity. And so for those of you who are not used to looking at spine deformity films, you can particularly see on this x-ray where this person is standing looking directly at the camera or at the x-ray that their shoulders are here. You can see their hips where we have these pink circles. And then you can see the spine, and there's actually this really large curve in the spine. And so that was causing multiple problems, compressing nerves, making it really, really hard to walk, to the point of not really being able to get out of bed, being on multiple opioid medications, needing walker, et cetera, to get around. And then also just really debilitating back pain. And so this is a software that many spine surgeons use, where we put in the patient's films and x-rays, and the software helps us to plan what type of surgery we're going to do. We tell it information about, oh, I'm thinking about instrumenting this level to this level, meaning I'm going to put screws and rods. I'm going to try to cut here to change things. And it actually spits out all these numbers of, hey, well, if you did this type of interbody, meaning you put a graft in between the bones to try to build it up, you'd get this much correction. If you cut here, you'd get this much correction. And then, by the time you put all these things together, you should be able to put a rod in that looks like this. And then when they will actually 3D print the rod for you and send it to you. And so your job is basically to fill in all the blanks and then put the rod in. I'd like to tell you that that's how swiftly it works out in real life, but that is the idea. I'll mention that a lot of this is based on other surgeons' data, or all of this is based on other surgeons' data. So they have created a very large database from all of us putting data into it, showing our films, sharing post-op films as well so they can see the results, and then creating through this AI software and engineering support these plans. You can see that as a surgeon, I can choose between, okay, what about this plan versus this plan? Which one do I think is more likely to fail? And I can make those assessments. I'll mention that Dr. Ali, who will be talking shortly, we were recently on a panel, and he talked about giving us the example of, putting something in here which is really complex, and having, ChatGPT look at these alignment models and see what they would pick. And how strikingly similar ChatGPT's selection may be to a surgeon's selection, despite the fact that, as you heard in my introduction, I have a pretty substantial background in neurosurgical training, as well as a spine fellowship. So the question is, can AI master the art of medicine? Because if we're going to start to rely on AI entirely, is it possible that AI can do it? And are there any gaps? There's a lot of really interesting articles that bridge both the traditionally academic literature as well as the popular mainstream literature about this idea. I don't know, many of you saw recently that Bill Gates said that AI would replace physicians in 10 years. So hopefully many of us are ready for early retirement. This article in Time I recommend is called "No AI Can Learn the Art of Medicine." And they talk about the things that AI can do, and they set the scenario or set the stage of what might have happened for a patient like mine coming from New York. So maybe this patient calls the office and they get an AI automated assistant that's going to answer the call. And so, it says, you're calling for this. Okay, you have back pain. Okay, you have leg pain. And they're moving through a series of prompts, and then they get, okay, now we see that, you may have this problem. Why don't you upload your x-rays? They upload their x-rays. The surgical plan is made. Dr. Ali, I'm sure, will talk a lot about his work in terms of surgical consenting and AI and ChatGPT being able to, or other large language models being able to help write a consent or tailor a consent. The consent is written. The patient comes to me. I use a robot that also has substantial data to help with spinal navigation. put in the navigation, use the 3D printed rod, and then I should get an expected outcome. And so you could see how potentially this could be very automated process. And they talk about some of the limitations and why that might not work. One of which is diagnostic limitations. So there's no context for symptom timing and urgency. If you were to say, I have leg pain and it's really difficult to walk, but you didn't have, you didn't say I have weakness, the AI is not going to be able to pick up or ask necessarily the difference between those two things. And may also say, okay, I, for example, recently had a family member who was coughing up blood, and they called and got a sort of prompt response, and the next appointment was June 2nd. Luckily, this person's well informed and said, "It doesn't sound quite right. I think I should probably go to the ER or try to call and make an appointment more quickly." But if you're next on the stopgap, there may not be an opportunity for evaluation or monitoring of those types of symptoms and that nuanced understanding of what the timing is and what the urgency is. There's also, human interaction needed to interpret communication at every step. So what I didn't tell you about this patient is that this patient had actually had multiple stab wounds prior to their abdomen, and that had caused part of this deformity, the spinal deformity, was post-traumatic. And they had a huge component of anxiety about their interaction with the healthcare system, about the safety of anesthesia. And there was going to be a lot of complexity when it came to the approach, which involved going through both the front of their belly and also their back. And AI may have easily missed several of those communication moments, while maybe, and I'll show some data later, that potentially the AI could respond to a feeling like anxiety. It may not be able to tease out or figure out that that was the cause of something if the patient just said, yes, I've been stabbed in the stomach before. There's also this idea of balance, where we need to prioritize this human connection, and especially when we're talking about surgery and reliance on AI, a huge part of why I went into surgery and why I enjoy surgery is creating that connection between the patient and surgeon, that ultimate entrustment or trust related to the preoperative process. So, interestingly, I have to argue with myself a little bit to say, is that all really true? Is this article, no AI could actually replace a physician, just us trying to flatter ourselves that we do something unique and connected that needs to involve a human? So there's some really interesting papers that have come out testing the AI's ability and large language model abilities to respond to things. And so there's been some questions that came from social media forums, like, ask your doctor, these types of things. And this is an article that was published in JAMA. And they had a physician respond and write a response. You can imagine also if you're a surgeon, you have an inbox, you're, looking, triaging these messages, writing about the patient's response, and then, or you have an AI chatbot answer the questions. And so it was statistically significant that patients actually preferred the chatbot response to the physician response. And so is it true that an AI can't communicate compassion or can't communicate the ability to give a patient an answer that makes them feel reassured or that they would like? Not necessarily. Is it true, though, however, that they may have missed things along the way, or that there may be other things that are important or valid for that patient's surgical plan and ultimate safety? I think that also is true. And so there's this idea of the human element of medicine. And so this article, which also looks at what is human about medicine and what could potentially be computerized about medicine, talks about this acronym of CARE: compassion, assistance, respect, and empathy. And that really encapsulates all these enduring values. So, and that's something that could potentially be missed if we over-rely on AI. So there's this idea of emotional support during an illness, caring, personal attention to patient needs. So in this particular scenario, I spent a lot of time with the patient as well as their family members in preparation for surgery, that an AI may not have known to do, or to invite a family member to the visit. And certainly if an algorithm predicts that that may or may not be the most efficient thing to do, or the best answer for every patient, that may not occur. Empathy, again, understanding patient experiences, and then this ability to individualize care. I think there are several examples where care can be individualized, but again, all these large language models are based on the data that we put in. And so if we're feeding in particular data from a particular patient set with particular decision making, of course, the answer is always going to be the large fusion or the large surgery, if that's the answer in the data that we feed it most commonly. So going back to this patient, what does that mean then? Does this patient actually need to come see me from New York, or can I just book them and put them in the next OR, or do I even need to book them? Can it just be an automated system? They get their pre-op labs and I'll meet them on the day of surgery. And so I think these are things that we really need to think about. And so what value do I add to this patient's care? So I can tell you that preoperatively, I had about 2 or 3 visits with this particular patient. Every time I found out something really useful that helped us to tailor our approach and our care. But I did also use the information that I gathered from putting this patient's information and imaging into the software. So I initially was planning to only do osteotomies or bone cuts at certain levels, and I added additional levels to make it look more like the blue plan, which I was ultimately more happy with, than the red plan, which I was less happy with, and I felt like would make her bend over or more bent forward. So I used the AI to my advantage. However, I was able to provide substantial psychosocial support, as well as gain a lot of information that was critical and honestly could have been life or death in terms of thinking about her prior surgical histories and how that would impact the ultimate plan. So some of the pros and cons of having AI in medicine, I think a part of the pro is rapid data analysis. So I was trained to do that kind of work that the software is doing for us now in terms of all those angles by, drawing physical, Cobb angle lines where the lines intersect, calculating the angle, subtracting it from another angle. Okay, how many degrees do you need? How many degrees can you get from each osteotomy? And this was like a 20, 30-minute process in clinic to go through and count each patient. And also, it's not necessarily the case that I'm going to do that exactly accurately each time. And I think we've shown many times, like when it comes to AI and chess, et cetera, that AIs are often better than us at doing some of these things in terms of rapid data analysis, recognizing patterns, telling exactly where an end plate is, where I might be squinting my eyes for, okay, does this look a little bit more white than this? Pattern recognition being a lot easier in terms of imaging assessment and assessment of patient patient variables. AI is also available 24/7. I do, in my ideal world, like to sleep. As Professor Shen pointed out, there are times when maybe, this patient would have waited for, 8 months to get an appointment, where potentially if this patient called and could get all their preoperative information uploaded and a plan that, ultimately I approve, could that save time? Sure. But what are those human advantages? I think without the contextual understanding, this patient's postoperative course could have been just a complete nightmare in terms of the psychosocial piece, in terms of the surgical considerations, the anatomical plan, that was not as simple as plugging in numbers to a database. This concept of emotional intelligence, which there's lots of excellent articles to judge whether or not we or an AI can actually emulate that. I think in some ways that article that I showed and many others about responding to messages show that there is some idea of being able to communicate in a way that patients find compassionate, but also this idea of ethical judgment. So is it the case that if that AI found out that this patient had, substantial anxiety, would it recommend surgery? Because if you look at the data for postoperative outcomes in spine surgery, unfortunately, patients with a lot of psychological comorbidities tend to have worse outcomes. So would it be the case that this patient is just told you're not a surgical candidate, based on the fact that they are showing certain variables that would lead to a worse outcome? I can tell you that payers are really interested in this data. And there is a possibility that some of this data could be used in a way that may not benefit all, or may not have tolerance in the system for variability when it comes to individual patient factors. And that is where part of the art of being a doctor, but I'll say even further, the art of being a surgeon is figuring out and tailoring a perioperative plan that fits your patient. And that may not be something that can occur in the setting of a over-reliance on AI. Patients are a lot less tolerate a lot less error from an AI than they do from a human. So I make sure when I'm explaining this model to my patient that I'm telling them this is, based on the averages of data from, however many, hundreds of thousands and millions of data points that they have in this database. My osteotomy is different from the person across the halls, from the person down the street, from the person on the other side of the world. And you may not get the correction automatically from this based on all kinds of anatomical and surgical factors. And it doesn't control the fact that, you're a human, you're going to be in the operating room, you're going to be exposed, you have a risk of infection. But as soon as people hear automation, robotics, there's been several studies that show that patients automatically assume more fault, basically, and expect more perfection. And that's something where, we all know in terms of surgical complications, comorbidities, that it's a complex world, and oversimplifying it in some ways by making it feel like it's data science takes a little bit away from what the surgeons are able to offer. The other, I think, really important piece to talk about in this is the possibility for bias. And that's what I was bringing up on this last idea of, what if a payer gets a hold of this data? What if every time, we all trained from the same surgeon and we all do our surgeries the exact same way, and we all put our data into this database, and then the right answer is going to be the answer in which that we trained the AI to do? That may leave us missing something that's really important for certain patients, for certain populations, for certain communities. And so I think it's really important. I know in the last talk, it was talked about of renewing and reviewing this data. So thinking about this data, thinking about the policies, thinking about the implications on an iterative basis, rather than accepting that this is fact, because we may have missed and then continue to train these AI with the wrong information. So I think, this is just an example of a study that Dr. Ali did and was kind enough to include me in, where we looked at the differences in actual surgeon representation when it comes in AI, when you generate text to an image. So when you look at, what does a surgeon look like to an AI, and you can actually see whether or not, in general, they were female, in general, they looked non-white, et cetera. And you can see that there was a huge bias in what a surgeon looks like and what a surgeon, how a surgeon could appear. So you can imagine if that can happen on the surgeon side, how that could also happen on the side of a patient. So overall, I think the key to bringing in AI, and ironically, I use AI assistants for this case. I use AI assistants for this PowerPoint. I use AI assistants in general. But there's a key, which is to balance that with human connection. And I hope that I showed that through this case, with communication, that I think is really important when someone picking up the phone and being able to communicate with that patient so that they don't just say, never mind, that it doesn't understand, and I'm not going to be able to come or get this surgery. Ultimately, this patient has a phenomenal quality of life. And so I think it's a really important message about how AI can potentially help us in surgery, but how not to over-rely on AI. So I think in general, the future of medicine includes being able to see where AI has limitations, but also leverage its strength and admit that it's here is really important, but maintaining that human touch and collaboration. These are some of the references, and I'd also be happy to answer questions or connect afterwards to do more work. Thanks.
Thank you so much, Theresa. Really looking forward to exploring some of the things that you brought up more in the discussion portion of today's session. But before that, our third and final speaker in today's session is Dr. Rohaid Ali. Dr. Ali is the chief resident in the Department of Neurosurgery at Brown University Health. His clinical interests encompass minimally invasive, oncologic, and robotic spine surgery, where he's emerged as a global leader in integrating artificial intelligence into clinical care. A graduate of the University of Pennsylvania, followed by Stanford University School of Medicine, his research aims to improve informed consent processes and healthcare accessibility for surgical patients, with a particular focus on AI-assisted voice reconstruction for patients with neurologic conditions. He's published widely on these topics and become recognized as a true global leader in this field. Upon completing residency later this spring, he'll become the inaugural spine surgery fellow in the Department of Neurosurgery at Harvard Medical School, training both at Massachusetts General Hospital and at Brigham and Women's Hospital. Today, Dr. Ali will speak to us about reclaiming voice with AI. Rohaid, please take it away.
Thank you so much for having me. And, it's a great opportunity. I'm looking forward to the questions. I know I have many of my own after the two outstanding talks right before me. So the title of my talk is called Reclaiming Voice with AI. We'll be going over briefly some of the strengths and limitations, just broadly speaking, of generative AI models, as well as a case-based approach to ethical and socially conscious AI deployment in the healthcare setting. The title of this talk is taken from a recent article we published in the New England Journal of Medicine AI with the same name. But I want to take us back just a few years to kind of how this explosion in interest in AI started, at least in healthcare in particular, and that's with the launch of ChatGPT in November 2022. Following that, you likely recall there was a number of studies showing how ChatGPT could pass various board exams within medicine, also in other fields as well, law, excels in business exams, etc. Our group was the first to study this as it pertained to the neurosurgery written boards. We found that GPT-4 time achieved a passing performance in the neurosurgery written board exams, as well as even taking into account imaging-based questions, which, if you recall, the time those models cannot analyze images. We followed it up with a subsequent study comparing the performance of ChatGPT versus Google's then Bard LLM on a question bank for people preparing for the neurosurgery oral board exam. So these were sort of higher order questions, more conceptual, more management driven, and found that that despite the longstanding reputation of Google at the time, ChatGPT, which is a newcomer, achieved a superior performance on the exam. And one finding that was kind of a secondary consideration in the process of writing and sharing this study had to do with this notion of hallucinations. So as I just mentioned, at the time, these models couldn't take in images, but in order to have the fairest possible assessment, we still included those questions in our assessment. We just didn't include the images. But a pattern that emerged while we did so was we noticed that certain models would confabulate imaging findings despite those images not being available for them to evaluate. And so it became very evident when, for example, we fed a question in GPT-4, which strictly, which nerves receive sensory input from the crosshatched area marked in the figure. There's no figure. And so GPT-4 responded, it can't see images or figures. But at the time, Google's leading LLM completely confabulated a finding. And from that, we were able to calculate the first calculation of hallucinations in the medical literature as it pertains to large language models. And little did we know this would be of immense interest to the broader AI community. It was a finding that would propagate in the AI space for many months to come in terms of a benchmark, finding that GPT-4 was hallucinating about 2% of the time, whereas Google's Bard hallucinated over 50% of the time, according to this benchmark. And so what other shortcomings exist for generative AIs in addition to hallucinations? Well, Dr. Williamson alluded to, she and I did a study together looking at bias and text-to-image models. So these text-to-image models, as I'm sure we all know at this point, can generate sometimes lifelike, if you want, images from a textual description. So if you generate a photo of a teddy bear on a skateboard in Times Square, it'll generate what appears to be a teddy bear on a skateboard in Times Square. And so to try to crudely get a sense of what the bias exists in these models, we asked it very bluntly, generate a photo of the face of and we chose 8 different types of surgeons: general surgeon, neurosurgeon, orthopedic surgeon, etc. And what we found was that not only did these models, two of the three leading models at the time, not only did it propagate biases, but it greatly amplified them to the extent that one model out of over 1,000 images, it not generate one image of a female or African-American surgeon, despite the fact that women make up about 30% of the surgical workforce, an increasing share of the trainee surgical workforce. And we published these findings in JAMA Surgery, and it was picked up, quite a bit by the news media, by NPR, by Boston Globe, and we think ultimately this finding didn't spread, because there's this fear that these models are going to, amplify biases of perception of surgeons. I think it's just a great illustration, really, of the biases inherent to training these models, right? The bias is inherent in the data itself, and it's a very difficult technical challenge to get around. And while it's very appreciable in this context, how that bias is manifesting, it may be less so in other contexts. So what we've learned is that LLMs can code rather sizable medical knowledge, but they have limitations as it pertains to hallucinations and outputs biased by training data. And so we published this article a year and a half ago about the urgency of neurosurgical leadership in the area of artificial intelligence. And essentially in this article, we outlined that, essentially there needs to be a clinician-in-the-loop model for successful deployment of AI in the clinical space. And so what exactly does that look like? Well, here are 2 case examples of that, real-world use cases of AI that we've implemented over the past couple of years. So the first is using AI to facilitate more informed medical consent. As we all know, the Bell-Bunt report was a landmark report published in 1978, which established the principles of informed consent, particularly as it pertains to human research, but that principle is then extrapolated to surgical consent as well. But we know in healthcare, we've long fallen short of that ideal. So in the New England Journal of Medicine in 1980, a report was published that found that on average, the readability of surgical consent forms was consistent with that of college or graduate student even reading level, despite the fact that 55% of Americans don't even read at a 6th grade reading level. And so, in medicine, we've fallen short for many decades in terms of this ideal of accessible readability. Other fields haven't. So after the Vietnam War, kind of a postmortem on that war found that the battlefield casualty rate and morbidity and mortality rate on the battlefield of soldiers was directly correlated with how proficient they were at reading, their educational background. And so as a result, the U.S. Military Technical Manual implemented standards such that all technical material would be written at an accessible reading level, middle school reading level, essentially. And we know in medicine that poor readability of consent form literature can have an effect on patients. So we published a study last year in Lancet's eClinical Medicine, the literacy barrier and clinical trial consents for retrospective analysis. We analyzed over 2 decades of clinical trial consent forms that were publicly accessible on clinicaltrials.gov. And we found that despite, again, 54% of Americans having a reading proficiency below the 6th grade, over the past 2 decades, on average, these consent forms are written at the level of a high school graduate or college freshman. And that's across different study categories, drugs, behavioral, biologic, etc. And further, we found that for every grade level increase in a clinical trial consent forms reading level, therefore, for every grade level increase, meaning it's less readable, we found it to be correlated with about a 15% increase in the clinical trials dropout rate. So we're finding that trials, and when controlled for a variety of different confounders, trials with patient-facing literature that had that were poorly readable, a higher patient dropout rate. So a real detriment to the quality of the clinical trial results. And so, is this a problem in surgical consent forms? We found in a study published last year that indeed it is. We took consent forms from 15 different institutions from across the country and found on average, these consent forms were written at the level of a college sophomore. So in order to get around this problem, we did a very simple prompt. We said, while preserving content and meaning, convert this consent form to the average American reading level. We pasted a clinical consent form rather into the prompt window, and what we found was that ChatGPT was able to consistently reduce the reading level of the consent form from that of a college student to now, on average, that of an 8th grade student. We found that the number of words per sentence, the number of syllables per word went down, and we also found that the mean word rarity also decreased as well with the simplification maneuver. Importantly, we had a medical malpractice attorney and clinicians review the simplified literature to ensure that the content and meaning were preserved, and we found that they were. And we published this in Nature's MPJ Digital Medicine to share our findings for this approach. And then the question was, could we implement this in real life at our own institution, the largest healthcare system in the state of Rhode Island, Brown University Health? We were in the process back then of actually revising our surgical consent form, so the timing was fortuitous. And we applied the same process. We took our healthcare system's new consent form and put it into ChatGPT, same simple prompt, while preserving content meaning, convert this to the average American reading level. And we were able to simplify the consent form to the 6th grade reading level, down from the reading level of a college freshman. And these are some examples side by side of what the original consent form looked like and what the new consent form looked like. This consent form was adopted by our healthcare system and is now what's being used for over 40,000 consents every year for procedures done across the healthcare system. It was picked up by the media and also by the government as well. A similar initiative now is being taken on by the VA. We've been able to share these findings across the country at the UN General Assembly meeting, at the NIH, here, of course. And we were able to publish this work in the New England Journal of Medicine AI using ChatGPT to facilitate truly informed medical consent. We were able to join the podcast as well as the first resident guests on the podcast. And so with that attention, we were then afforded access to some frontier AI technology, collaborating with OpenAI. And this project is called Reclaiming Voice with AI. Just to give you a backdrop of the problem, so about 18 million adults have problems with their voice in the past year. This is according to the NIH. 5% of children have a speech disorder. About 2 million people in the United States currently have aphasia. And these include patients like Lexi Bogan. She presented with 6 months of headache, dizziness, nausea, facial tingling, blurry vision. And it went a 10-hour suboccipital craniectomy for a gross-floor resection of a hemangioblastoma compressing our brainstem, her lower cranial nerves. Postoperatively, she had dysarthria and also dysphagia, requiring a trach and a G-tube respectively, both of which were subsequently removed. It was around this time that, due to our work with consent forms, we were granted early access to OpenAI's voice engine. This is a type of voice cloning technology has now been replicated by other AI labs as well, but essentially what it can do is it can take 15 seconds of recorded audio, someone speaking, and recapitulate that voice. So it just requires 15 seconds. A lot of people hear about this in a negative context, in the context of deepfakes. We immediately thought of a patient like Lexi and what this sort of technology could do for patients like her in helping her reclaim her voice while she was recuperating it after surviving brain cancer. And so I hope you can hear this audio that I'm about to play here. If not, please let me know. But this is what her voice sounded like in a pre-recorded audio.
When you have all of your ingredients together, you are going to put the chopped broccoli and chopped banana peppers inside the bowl. And now this is very adverse. You can use anything that you would like. If you want to use cucumbers, you can chop up cucumbers and put this in here.
Okay, so that was audio from prior to her surgery for a school project she had done in her senior year of high school.
Hi everyone, this is what my voice sounds like using OpenAI's new text-to-speech model called Voice Engine. I was able to use just 15 seconds of a video that I made for a class project to be the reference audio source for the voice you hear right now. What do you think?
This is what her voice at the time actually sounded like.
Hi everyone, this is what my voice sounds like using OpenAI new text-to-speech model called Voice Engine. I was able to use this 15 seconds of a video I made for a class project to be a reference audio source for the voice you hear right now. What do you think?
This is her now using the technology to order food at a drive-thru.
Can I please have a number 1 with large fries and with a strawberry shake?
So we published this experience with Lexi. Actually, Lexi was we included as a co-author on the paper because we felt it was a great example of, I think, what Francis Shen alluded to earlier, which is, at what cost is failing to deploy AI technology having on patients when we have technology that we know that could potentially help patients, in this case, Lexi, helping her get back to college, communicate even with loved ones, order food in a drive-through, answer questions with confidence in the classroom, speak at her sister's wedding. All these things are meaningful to patients, right? And so how can we define socially conscientious ways of deploying these advanced AI tools in a way that's not harmful to society at large? And so in this particular instance, what we did was she had a bespoke version of an application on her phone that was only tailored to her voice that she could then go around using with a text-to-speech essentially model that recapitulated her voice. She found it very helpful as she was undergoing speech rehabilitation and recuperating her voice in a several-month period. It's almost like a prescription-based model. You're prescribing, an application to a patient in a bespoke fashion, just tailored to their voice. But this is the sort of thinking that we think is, I think, demanded of clinicians in the 21st century, especially in the era of generative AI, in terms of deploying these technologies in a socially responsible way. Lexi, I think, viewed this as not only an opportunity to, help herself, but honestly to also serve as a role model to other patients. She movingly describes, sitting in the clinic and seeing patients with voice disorders and hearing the sort of solutions that were offered to them in terms of voice boxes and how it sounded, just frighteningly robotic, and how she felt that if she used this technology, it could help normalize it for others to do the same. And so I think ultimately at the end of the day, this should be our guiding light as clinicians, using the patients ourselves as being our guideposts on this in terms of how to effectively deploy these AI tools. That I'm happy to answer any questions. Thank you.
Thank you, Rohaid. That was spectacular. And thank you to all three of our speakers, to Dr. Shen, Dr. Williamson, Dr. Ali, for some really, really spectacular talks, and really some great jumping off points for our Q&A session. We have a little over a half an hour now for question and answer, and we already have a handful of questions coming through in the Q&A box. Please feel free to continue putting questions in there. As our speakers are all bringing themselves back onto video. To start things off, each of you has alluded to a little bit, either directly or indirectly, kind of the forward thinking, where will AI be? Where will we be without AI? Francis alluded to that a little bit. Rohaid talked a little bit about some of the things we can already do with AI today, as did Theresa. I wonder if you guys all might look into your crystal balls a little bit and see and explore some of the different ways that you could imagine AI being used well, and AI being used perhaps less well 5-10 years into the future.
I'm happy to start. We had a conversation about this at a recent conference that was just here in Boston for neurosurgeons, and we were talking about the future of AI. And I think one big point is we talk about the future of AI a lot, and I'm not the earliest adopter, but AI is kind of here, or not kind of, it is here. And in terms of, what's capable, I constantly feel like when I'm discovering new tools in AI that I'm discovering magic tricks. It's like unbelievable, kind of some of the things that can be done. And so I think we're getting examples just from surgery every day. I think some of the things that it can do really well, I care a lot about well-being and surgeon well-being. And so, writing notes, doing things like, tracking down additional information. My APP, I don't think would be ashamed for me to say that, she uses it whenever we have to write like peer-to-peer letters, and like, obviously there's an important component of oversight, human oversight that goes into those things. But I do think there's an opportunity to, actually connect with patients more, because we have automated some of the administrative burden of associated with, the EMR and being a surgeon. So I think that's one potential benefit. I think from the patient perspective, I think there is a benefit to us as surgeons knowing what we do and what we do well, and seeing that modeled to help us to make decisions. I think that's all great. I think where it could potentially be misused is, it only has the data that we give it. And so potentially if we give data that sort of supports a certain finding or certain end, we may just continue to, write not error, but, not the most nuanced or innovative or patient-centered or community-based approaches into sort of law because of the fact that that's what we're doing. And then I think I alluded to in my talk also in terms of the positive, negative, just the justification for payers of what we do, and how AI could be used in a beneficial way in that sense, but also has already been used in ways that are not necessarily beneficial to patients.
Francis, any additional thoughts?
Yeah, just a couple. One is that I think the history of AI in other spheres cautions us to not make the mistake that what's easy for us will be easy for AI, and that's what hard for us will be hard for AI. And I think a good example is chess. Chess is really hard for us, and people thought, oh my goodness, chess is going to be hard. Chess was actually pretty easy for AI. But there's this great comic I should have gotten that sort of says, to avoid the AI apocalypse, just close the door. Because turning a door handle, like getting a robot, is actually much more difficult than playing chess. And so, I'm not a surgeon, so I'm not going to venture and try to figure out what's in the bucket that will be easier for different AI systems to do and what's harder. But I am guessing that it might not be coterminous with what's easy and hard for humans to do. That's one thing. And the second is that, Dr. Ali, I really liked your presentation. I think that human hubris could get in the way. The movie portrayals of these AI gone wrong almost always give us a human hero, and they're a hero because they sort of resist the AI. They're the one person who hasn't given into it. I think it may actually be the case that in many instances that hubris gets in the way, and that it actually would have been better to sort of follow the Google Maps. And I'll give you a concrete example, which is that I love my mother to death, but she would never use Google Maps because she has gone certain ways, certain times, and she just knows the way to go. If you're listening, Mom, I'm sorry for throwing you under the bus. You're catching strays, but sometimes Google Maps is just a lot better because it has all this. It hasn't been around for 50 years, but it's got all this information about current traffic flow. And it's just like, that would have been the better place. Now, the last thing I'll say, however, in defense of my mother, and to complicate matters, is whether or not Google Maps is the right thing to use depends on what it is we're trying to do. And if the goal is, I just want to get from A to B as fast as possible, then yes, we should take Google Maps way and not my mother's way. But maybe that's not the goal. In the same way that if someone's running out on the Charles River from A to B, they could get on a bike or in a car and go from A to B much faster. But they'd look at you cross-eyed. You'd say, why don't you just get in my car? Because my point is not to get from A to B faster. So there's kind of my point in the slides that there has to be some conversation about what is driving me. Why do I want to do this? And if it's aligned with my goals, maybe patient care, great, but maybe not. So that's all I'd say.
I would just say that I think I'm a long-term optimist, but a short-term pessimist as it relates to AI and the effect on healthcare. I think that in the long term, we're going to see the additive effects of having genius level large language models inform scientific research, inform scientific questions, experiments, et cetera. And there will be benefits from that. In the short term, however, I think that we are going to be in some choppy waters for the foreseeable future in healthcare. AI makes everyone an expert, and that includes health insurers, that includes policymakers. I think it's I don't think there are, enough lawyers out there who are seasoned experts of like the law, laws of the executive branch to be able to write hundreds of executive orders, right? With such surgical precision. I think we're clearly seeing the effects of LLMs on society at scale, right? And that is, it's having effect, whether it's good or bad, depending on your political leanings, it's having effect, and that should give us pause and at least some consideration. We know that health insurers are contracting out with third parties, like Cohere, for example, to use proprietary large language models to decide on denials for patients. By one metric, one payer was denying 1.2 claims per second, which can only be done in the era of AI. And so how do we as clinicians respond to that, or in an organized fashion that keeps the interests of the patient at its core? It's going to be a challenge for our era of clinicians, doctors, and I think it's, and policymakers, researchers, scientists all over. So it's going to be a very formidable challenge. But I think that's why this makes it all worthwhile to have conversations like this one.
Just a quick note on what Rohaid just said about the payers. I went to a conference recently that was sort of at the intersection of industry and data, thinking about some of the software that we use for surgical planning, actually initiating the plan. And some of these industries are actually seeing themselves now as data companies, less so than hardware companies, right? Because so much is done in the data, and that's our patients' data, right? And interestingly, at that meeting and in many of the panels and with a lot of interest were payers. And one of the payers I thought made a really good point that, it was sort of like, well, we don't want you to have this data. And their answer was, we already have it. And so I think that, the reality is, how can we guide or be involved with the way that data is utilized? I think the role for a surgeon is unbelievably important in this short term to sort of mitigate some of Rohaid's short-term pessimism.
So Building off of a couple of the comments that responses from each of you, one of the questions that was posed is with regards to surgical training. How do people foresee surgical training evolving in the future, and how can we ensure that AI has its sort of appropriate role, whatever its appropriate role might be, in the training of tomorrow's surgeons?
So Dr. Williamson and I just published a study in the Journal of Neurosurgery using, so what we did was, so I think every specialty has this, but basically a specialty board exam, question bank, right? And as you can imagine, creating the answer explanations for these question banks takes many, many hours of work across many, many professionals, right? But what we did was we had a LLM that was specifically trained on neurosurgery papers. It was a RAG model, to get technical, using GPT-4. And we asked to generate answer explanations for certain multiple choice questions. Said, hey, here's a multiple choice question. Here's the right answer. Provide an answer justification that can educate the user of this, exam question bank. And then we compared it. We had 15 neurosurgeons in a blinded fashion compare the explanations from the question bank, again, written by expert clinicians, compared it to the AI. The AI won. It was found to be more comprehensive, better referenced. And so, hopefully that means in a way that's going to be very democratizing for education and allow surgeons to gain access to information in a way that's faster, more accessible, and more relevant. So that's at least one way where I can see AI having a positive impact on education.
I agree. As someone who has spent volunteer hours writing answers to questions and searching people down to help write answers to questions, there's also a lot of human error in that process, right? Like I might answer a question based on my own training, and I might not be as up to date on all the data from everything, or in my spare 1 hour on a Saturday morning to try to write these answers to the questions may not do a comprehensive literature review that ChatGPT can do in 45 seconds. I would also say, however, and I think I always make that point to the residents. As I started residency and then finishing, there was a huge difference in the knowledge that was available to me easily, right? Like I started residency with sit down and read a book, and I ended residency with type it in to an online textbook repository, and get the whatever the name of the case I was doing the next day. I would put it in, and I would have 6 videos curated for myself, as well as the pertinent data. And I was like, it's almost like cheating, like it's so easy to be able to get this information to yourself quickly. I think the piece that's a little bit nerve-wracking is sometimes when I put something into just Google, right? Like if I Google something for a surgery, the AI overview can be really odd, where they picked the paper from, what they describe, what's important. And you may have, trainees taking a little bit too much of a shortcut, which I think is a little bit, unintentionally, which is a little bit scary. I think the other piece of it is when we think about automating surgery and surgical planning, I don't think any of us has yet come up with the balance of how to teach a trainee to both use that data and information and without having done it by hand first, right? So, okay, you learn to write, the alphabet, and then you learn to type. But what if you just learned to type and you never really learned to write? I mean, a lot of things like that are already happening. And does that mean that you would never learn to write great essays if you never learned to write by hand? Like probably not. And so I think the reality is we feel, I think maybe to justify a lot of our own hours of struggle in the, in the OR, that it's all necessary. You have to learn how to do this by hand. You had to learn how to do this without robotics or without AI planning. But I think there is a way to teach, and it's kind of our obligation as surgeons to evolve to teach according to what is available in the time. And that also means that we have to use it and we have to try it, right? Like we can't just say, I'm going to keep doing this and my resident's going to keep doing that. And then I'll just judge whether or not they can keep up with me, because the answer is they can. And I think that, we need to be able to do that. And yeah, I think the last point I'll make is just that one again about EMR and the amount of time. There's a great paper by Anthony DiGiorgio, who's out at UCSF in neurosurgery, who actually looked at the epic hours that an on-call resident, junior resident, was on the computer. And it was something like 16 hours for a 24-hour shift. And so if we can get the residents away from the computer, we can teach them a whole lot more. So I think there is some benefit to that too.
We also have a couple of questions that have come in with regard to regulation of AI, whether under the auspices of FDA or other regulatory bodies. I wonder if you might speak to a little bit what you see now and in the future with regard to regulation, what is and what perhaps ought to be in that space. I'll throw this first, Francis, to you as the legal and policy expert amongst our team.
Yeah, well, it's a great set of questions. I think one of the questions, like, will there be more regulation? The answer, absolutely yes. The leading international regulation actually comes from the EU. Last year, the EU AI Act really rocked the world, and depending on your views on it, for good, for bad, but is definitely the anchor. FDA lags behind that. And, some of the critical distinctions that were made in the EU AI Act that will surely be made in regulation here are distinguishing between different types of AI, in particular by its potential harm, and then regulating more the greater the potential for harm and less, if it's considered to be less potentially dangerous. One of the major challenges that's difficult with regulating AI in this space, let's use large language models as an example, and there are others, is that the system itself is different on Tuesday than it was on Monday because it's learning. There are efforts to try and sort of navigate this and strategies that have been proposed, and I'm sure some of them will eventually be adopted. But we are in a transitional time. The case law, for instance, the tort law, just hasn't evolved yet. We don't have enough cases. Actually, in some cases, we don't have any. So it will respond in, that's part of the regulation, right? Is the case law, the federal law, and then state law in the United States, just to be US-centric for a second. State law is going to matter a lot as well. The best example I'd give is, the last time you did something and it asked, do you live in California, this state or that state, right? We may very well see that sort of thing. California's been a leader on data privacy. I suspect they'll be a leader here again, also because Silicon Valley's there. And the last thing I'll say is that when there's regulation, that means there's politics. And the politics of AI will be very interesting to see. I'll just lay out, imagine that you have a policy that might be perceived as racially biased, harmful to the environment, and challenging labor. Who do you think might resist, right? And on the other hand, it's a policy that threatens, human autonomy in the center of the human resist. So it's really unclear to me exactly how it's going to play out. But I guarantee that politics will be a big part of that, which means that, again, hospitals are going to be in the cross sections as they are right now. And it won't be policy that's made by, disimpassioned experts sort of sitting around and trying to think about patient security and patient outcomes. And in part, they'll be there, but there'll be a lot of other considerations on the table as well. And we're already starting to see that.
Can't imagine a world in which politics plays a role in healthcare practice.
Yeah, me neither. Yeah.
Theresa, Rohaid, any additional thoughts on the regulatory question?
Yeah, it's interesting with our clinical trial consent project. One of the most fascinating things to me as a trainee, just looking at blankly, is in the Code of Federal Regulations, it's abundantly clear that any federally funded study has to have in patient literature its consent form at the minimum, accessible language, right? That's in the Code of Federal Regulations. And we have over 2 decades of data that we're showing that regulation is violated, over and over and over again. There's not a single study, I think, that met that requirement. And so it's an interesting question, right? How many of these regulations will actually be enforced and how will they be enforced selectively? And again, I think that brings into the question politics at play.
Yeah, I think it's also even on the hospital policy level, I think it's at the current moment sort of an organizational ethics failure is the lack of leadership embrace of AI. And I think the sort of turning a blind eye to like, okay, well, my early adopters are doing, AI, and I'm not going to sort of create policy around that. I think it's a real need area. I really liked Francis's list of 5 things, and I think that that should really be required in terms of hospital administration, because I can think of, certainly there's a lot of rules and a lot of things that I have to say on an informed consent. I do not have to tell any patients, at least on our informed consent paperwork, about my use of their data and where their data may or may not be going.
Staying with the regulatory side of things for a moment, in healthcare, we as clinicians and researchers classically are not super excited about having outside bodies come in and tell us what to do, how to practice, things like that. So do we think that this, whether it's regulation of AI from an outside body at the level of FDA or another governmental body, or even at the institutional policy level, ought AI in healthcare have kind of similar guidances, similar rules, as it were, to AI utilized outside of the healthcare space?
I think that and I know that this is a controversial thing. I'm of the belief that we should put doctors in the driver's seat and providers in the driver's seat and place more trust on them to be discerning about these tools. I think there's always that concern that AI hallucinates, therefore we're going to start operating on the wrong side of patients. Errors are going to happen, human error happens, but I think that there should be an expectation in the culture of medicine that you question these things, that you critically examine these things. That's part of using this technology. And I think that, yeah, that's just my take. And the other element of this, I think we haven't discussed yet, which I think is really important, is if you look at the American Academy of Professional Coders website, they have all these certification exams, certified professional coder, certified risk auditor, inpatient coder. They even have subspecialty certifications, orthopedics, biller, like family medicine coder, et cetera, like 20, 30 different certifications. Collectively, these people, right, affect the $4.5 trillion worth of money that flow through the US healthcare system every year. We're just talking right now about AI augmenting clinician output, right? But what about how this technology is going to be affecting the rest of the clinic, right? And I think the impacts of that will be profound, and either clinicians will be passive in this moment, or we're going to be taking a seat at the driver's table and really redefining what the clinic of tomorrow looks like.
Yeah, I think that's an excellent point. I think especially maybe in surgery, the image is of surgeon doing their procedure and how AI would affect that, but everything around that procedure is going to change. And one example that a colleague gave recently has always stuck with me, and he talked about his friend who went into the ER, and I forget what the particular ailment was, but it needed a read on a scan. And it was in queue to be read by a human radiologist, and it took so long that he ended up dying before it could be read and properly evaluated. And the idea was that this could have been screened by, an AI in moments. So that's, potential positive use. Interesting, Dr. Lee, where you talk about a sort of clinicians being in the driver's seat. Interestingly enough, that's what a lot of the AI developers want as well. And the reason is for liability purposes. So on one hand, in the world of medical imaging, where AI has done spectacular things, and actually was kind of one of the bleeding edges, on one hand, to sell the product, to say to the hospital, this is an amazing technology, look what it can do, it can detect A, B, and C. When it comes to liability, the answer is, the framing is, all we're doing is being a clinical support tool. We're just all we do is provide information to the clinician. The clinician's the one who makes the decision. That's the person you blame if something goes wrong. Liability right now is unclear. As I mentioned, the tort law is unclear. Products liability is difficult because it's being framed as a service, not a product. And FDA regulation is interesting as well, because FDA generally doesn't monitor clinical decision making. You know, it monitors the product. So it will be very interesting to see where it goes. But I'll say right now it's unclear on the law side.
For instance, I've asked this before to other radiologists and AI, but when do you think the first medical malpractice lawsuit will be for a clinician not using AI? You know, for mammograms, for example, AI has already been shown to, in some cases, exceed human performance, right? And this is published in leading subspecialty journals. At what point do you think you're going to see the reverse of what the concern that you're pointing out?
Yeah, so it takes a little while because tort law is conservative, meaning it's more like, which is why hospitals and many other institutions, education just tend to be conservative. It's harder to win a case to say, this has been the standard of care for the last 10 years, and you're liable because you didn't follow it because it, hadn't updated. So two things will happen that could change this. One, the professional bodies will change their standards of care, and somebody's not going to follow them. And that's the most straightforward. Professional bodies, listen up, you're going to have to update your care. I could actually see a world in which the right set of facts emerge that are very favorable. And one that I could see is where physician A decides to stick with the status quo and not use AI. The AI said to do something different, and so did another human, actually. And so now it kind of feels a little bit more like what we've seen. So I could do something like that. It'll take a little bit more time. But I mean, we haven't talked about professional bodies either. I don't know. I know you're all moved to different American Congress of Surgeon. You're going to play such a huge role in deciding the future here. If you speak out one way or the other, like it's ready, it's not ready, I mean, law will basically adopt that, I think, as a standard of care. So in some ways it will be in your head. If I could just ask that question, is there a conversation already to establish new consensus recommendations in some of your areas on AI use?
It's interesting. I sit on one of our Congress boards, and there's a huge push for, understanding and using this, and but there's a drag. And I was actually thinking, man, next meeting I really need to bring this up, because there is a lag when it comes to discussion of what the actual policies should be around it, and where we should go with that. I think, probably usually our professional societies kind of follow the order of doing like a guideline first, or like a systematic review, and then a guideline, and then, getting a ton of expert consensus, interprofessional society consensus, for the reason of, understanding that, these are the things that come up later of, hey, this is what the society said. So, now it's your turn. But I think the conversation is at least starting to be had. I don't know of a, Rohaid, I don't know if you know of one, but I don't know of a society that has a policy out there yet, other than everybody just saying it's a support for clinical decision making.
Without listing the specialty, I know of at least one conversation in a different specialty. It was primarily knowledge processing specialty, let's put it that way, where a proposal was put out there for an AGI governance framework. And the leader of that specialty in that organization said, my fiduciary responsibility as the president of this organization is to every member of this organization, which means I need to do everything in my part to prevent this technology from being applied.
Wow.
And we need to be using the power of organization and throwing credentialing, hurdles to prevent the spread of this. So I think you're going to see an interesting tension play with the societies in the coming years in terms of how they go about this. Yeah.
That's a really interesting point. It was one of the top 10 labor market issues. Wow, it's right there.
I mean, that's certainly been what we've seen historically with a lot of our professional societies, of they're making decisions that are trying to maintain the status quo for the labor market, or for physicians, for surgeons, and sometimes at the expense of whether it's physician assistants or other people throughout the healthcare ecosystem. And with that in mind, how do we navigate this balance? I mean, each of you have alluded to in one form or another sort of this clinician-guided, complementary path forward between AI and human. But there is this inherent tension of even if the goal is complementary, if the goal is us working together with AI to do something better than either of us, either of the two entities could do individually. How do we do so in a way that doesn't make people feel AI is coming for my jobs, or the payers are simply going to replace me with a chatbot or a robot? How do we balance these things?
I think it's really rather tricky. We were in a meeting earlier today where someone said, I think where the institution is probably going is that my job is going to be an AI job, and physicians will basically be able to sort of self-serve. I know at Mass General Hospital we now have a robot coffee stand, and so you can get a robotic latte. And you order and it tells you to have a nice day and don't forget to stir your cup, and it can make pretty much any flavor of latte, etc. And so, okay, at what point is that human interaction of the person that you meet at the cafe in the morning every week, and that person's job just not going to exist? And it's important for people, obviously, livelihoods, etc. I think one thing that I think this is not an answer to the question of what we do right, but I think one thing we're doing wrong is this concept of like, it's always just going to be an aid and we'll check it, right? Rather than like a true integration of like how we will use AI in these different ways, or how we might be able to facilitate jobs that are more nuanced than just, being the checker of the AI's work. I think is important. And I think, that's what I tried to bring up in my talk, like some of the roles and the things that we do that are so critical and so important. I think someone brought up in the Q&A, like the data we also feed, like we create the research that feeds these models. And so the data that we're creating and what we're saying is what's ultimately being basically reproduced in a reliable way from these models. And so I do think we still have a tremendous role in that process, and actually remembering that like we are the creator of these models is really important, versus like these models are doing what they're going to do and we'll just check to see if it's correct.
Yeah, I'd agree with that, and just add that transparency, which is a really core ethical value in AI, and of course in many other areas, I think is tremendously important because it's so correlated with trust. And I could see a lot of these different relationships that have been brought up really suffering right now. The public is very skeptical. Large segments of the public are very skeptical, understandably, about AI. They're going to see many headlines because they'll just be cherry picked. Of the good example actually are self-driving cars. If a self-driving car crashes, it's front page, top of the news on social media. The tens of thousands of human car crashes that day don't get mentioned. And so navigating the narrative is an important part of it. And I think for the clinician patient trust as well. It will be interesting for me as well. I've been showed all three of your clinicians what it will feel like when patients empowered by AI come in and say, well, here's what the AI said. And what they tell you is something pretty remarkable because the AI had the strength of 10,000 physicians. So I guess my overall, if I had to pick one word, it'd be transparency. It doesn't solve it, but at least procedurally, I think it starts to move us in the right direction.
So we just have a couple of minutes left. I wanted to see if each of the three of you, in the spirit of ethics education, if you had a final hope or a final take-home point that you'd like people to come away with from today's session as we think about the future of AI in surgery and more generally.
Yeah, I guess I'll start. I'll just emphasize what I said in the slides. I think it's really important to write out, both for an individual and then especially for the unit, whatever, or units. And you can cover if you don't like the word policy, just your thoughts on what should be happening. And the reason I think that's so important is, again, procedurally, it will allow you to think about, well, what do I want to happen? What values do I have? And then concretely, there's some guidance, and there are some low-hanging fruit that should be in every policy, such as ChatGPT is not HIPAA compliant. So if I'm going to use LLM, I'm going to use Microsoft Copilot or whatever my instance, like that. Everyone in the group should know that at a minimum. And there are some other things that should just be in that we should know that. I don't think everyone does. So go write something down. And that would be my plea to you, and tell others to do the same.
Yeah, I would say incorporate it into your practice, because I think many of us kind of sit behind it and say like, oh yeah, that might be cool. But I think incorporate it so you know what you're working with, and where these models are. I know Rohaid gave a great talk recently on this and said like, just go put it in your phone, right? Go do it, like do it now, and understand what is possible, because I think that is really critically important. And then I think involve patients and communities in the decisions around how these models are used. So I think, talking to patients about where their data is going, and finding ways to have those conversations that actually seem relevant, I think is really important.
Yeah, I mean, I would just echo what Francis and Theresa are both saying, is just to, just be action oriented, do something, right? Make a policy, use it in your day to day, because you don't know where its strengths and weaknesses are until you actually use it. In this case, I was sharing with the group, we had our national meeting this weekend, and I mean, sometimes there are very technical slides, even within neurosurgery, different areas within it that you just don't completely follow. I just took a picture of the slide on my phone. ChatGPT asked it to explain it to me, and you'll just be amazed at how advanced these tools are. And I think they can be very well utilized to solve what were previously, collective action problems, right? Like surgical consents. It was a problem that's been written about for over 4 decades, known about, but no singular person had the expertise necessary. Maybe Francis does, but the law, medicine, everything, all in one, to solve that problem, right? Simplification, as an expertise, right? So try to, if something feels off, make yourself an expert quickly using AI and try to solve those problems. I think that's the best you can make out of this moment.
All right. Well, thank you so much, Theresa, Rohaid, and Francis. As any good ethics session should, I think we probably left people with many more questions than answers. And this seems like the topic where that's more relevant than just about anything else. So thanks to each of you, and thanks to everybody for joining us. I will pass things back to Doug Hanto for a couple of closing thoughts.
Thanks, John. I'd like to thank our presenters tonight, Dr. Shen, Dr. Williamson, and Dr. Ali, and our moderator, Dr. Marron, for their outstanding presentations and discussions of the critical ethical issues arising from the lightning advances and implementation of AI in the practice of medicine and surgery. I would like to thank all of you who listened tonight and asked questions of our panel. I would like to also thank Dr. Rebecca Brendel, the Director of the Center for Bioethics, Dr. Wes Boyd, Director of Education in the Center for Bioethics, and again, Dr. Marron, Director of Clinical Ethics in the Center for Bioethics, for their unfailing support of this conference. Finally, I would like to thank Jay Cohen, Victoria Cunningham, Courtney Lombard, Leslie Nicolini, Melissa Nozel, and Noah Venuti for their organizational, marketing, technical, graphic, and regulatory support of this conference. On behalf of the Surgical Ethics Working Group, we thank you for attending. We hope that you've enjoyed and learned from tonight's presentations. We hope that there is information that you will be able to use as you address bioethical issues in the future. We look forward to seeing you at our next Harvard Surgical Education Conference in 2026. If you have topics that you would like to see covered, please put them in the evaluation form. Thank you once again, and good night.